Well, we use a quantitative immunofluorescence approach, and fluorescence has a broader dynamic range than chromogenic measurements, which is what traditionally is done. But they haven't caught on, fluorescence hasn't caught on because pathologists don't like the fact that you can't actually see the tissue that you're measuring. You can see it, but it's not counterstained with hematoxylin, which is the way we've become accustomed to measuring these things. And so it's failed to gain popularity, I think, largely because the tradition, it sort of doesn't, it's not the traditional approach. On the other hand, it's more accurate, it's got twice as much dynamic range, it's more sensitive, and it's more reproducible. So those things should eventually move the field in that direction. And I think especially we'll see the fluorescence approaches taking off once standardization becomes more important. Right now, we just do a single positive and a single negative control, and as a result of that, there's probably between a 10 and 20% false negative and false positive rate in most immunohistochemistry assays. The FDA approves and clears drugs and platforms and antibodies, and despite that FDA clearance, there's still as much as a 20% discrepancy between two CLIA-certified labs. And so that suggests that some better test is needed, and as we get to more sophisticated drugs, I think that will be sort of the push or the driver for those more sophisticated assays.